higher federal and state reimbursements. We're able to shift budget within the adult Arrowhead Behavioral Health Initiative grant funding and receive slightly higher reimbursement shown under the miscellaneous line. Overall expenditures were 6% more than the budget. Again, this was largely due to the increased social services program related cost, increased out-of-home placement cost, mental health placement cost, both adult and children, and increased mobile crisis response program cost. We had budgeted to use $566,645 of fund balance. We have an excess of expenditures paid over the revenues received of $155,887. This is the amount of actual use of fund balance. Any questions?
Mr. Chair.
Please.
The miscellaneous, can you just give us a general idea?
So on the dot line, there aren't very many items except the Arrowhead Behavioral Health Initiative. That's funding we receive to support our adult mental health worker. During 2025, there was an opportunity to shift funds from Grant 11, what it's called, it's a block grant, brass grant related under adult mental health, towards the support for salaries for the adult mental health worker. So that's why you see an increase under that line. But basically, it was a change in the budget along the way, and we were able to charge salaries in French rather than program supplies, and that's why that is at 148%.
Normally, and thank you for that, when you have a significant expenditure in a particular area, it becomes its own line item. And so that's why when I look at miscellaneous, because it is the highest of the overage, 148% of what was budgeted, and wanting to understand what is that, if it is largely from the mental health component, then I guess the question is, why isn't that a separate line item that makes it clear when you're looking at it, as opposed to having it lumped in with miscellaneous?
Well, because I've separated, well, first of all, it's a large percentage, but it's a small dollar amount. And second, I have to separate, I've been separating those financials between federal and state, county levy, charges for services, and miscellaneous, just to display how PHHS is funded. That's a one condensed picture of all the financials, and I'm going to get further down into the greater detail for each department.
Thank you.
Federal, so that graph represents where the funding sources are for public health and human services. And then the other chart compares public health and human services revenues against the county tax. So the first graph, federal grants and aid made 21% of our revenue in 2025. State grants and aid made 25% of our revenue in 2025. Combined, the federal and state revenue made 46% of the revenues in 2025, which represent an increase of 4% from year 2024. Okay? Fees and recoveries, including reimbursement from health insurance plans and license fees, made up another 6%. Small amount of revenue came from non-governmental grants and donations, less than 2%, and the remaining 46% of our revenue came from county tax. The second graph represents a comparison between the county tax and all other sources of revenue between 2022 and 2025. Please note that in year 2023, 2024, and 2025, all other sources of revenue exceeded the county tax.
Say that one more time.
Except for year 2022, all the rest of the years, all other sources of revenue are higher than the county tax. Okay,
When,
any questions?
yeah, just going back to the previous discussion about miscellaneous, where would that fit in that revenue fit into the pie graph there? The pie chart? Is that other grants
That would
donation?
be
or is that-
under other grants
Yeah.
and donations, yes.
Thank you.
Yep. Any questions on this slide? Okay. The 2025 expenditures by department, all of the public health and human services expenses fall into one of those departments. Economic assistance, public health, including the public health community grants. It's an important note. Child care program and social services. For economic assistance, their share is 21%, public health 19%, child care program 7%, social services 53%. Any questions? I always try to present the org chart for public health and human services. At the time I prepared this as of January of 2026. This is what staff at Public Health and Human Services was. Of course, we've since had another change under behavioral health team and under the public health team too, with Avi Sukwal joining the team as a public health supervisor. I'm going to start with the administration, since it was the Administrative Professional Day on April the 22nd. I would like to acknowledge our administrative staff for important work that gets done behind the scenes every day. This includes our director, providing agency management and leadership, and local, regional, and state collaboration, the executive administrative assistant. Amongst various other responsibilities, the administrative assistant supports our citizen advisory councils and maintains the public health and human services social media and outreach. The administrative team also includes the fiscal services with one supervisor, a fiscal officer, and an accounting technician. We develop the budget, pay the bills, receive the revenue, operate the social security REPI program, provide complex grant management and reporting, provide regular financial reports to the board. Kudos to my team for the work they do.
Here, here.
Administrative allocation, the administrative cost that benefits the entire agency is split between the three departments. That includes administrative wages for a team that I just went over, postage, copy cost, office supplies, phones, training, travel for admin staff, travel per diem for advisory council board members, fees to the state of Minnesota for the merit system, as well as funds transferred to the county general fund for courthouse office rent and county MIS cost and labor, liability insurance, and annual audit. As I go over the details of each department, you'll notice a line item in each budget for administrative allocation, as these admin costs are split proportionally between economic assistance, social services, and public health team based on the AFTEs.
Based on what?
Full-time equivalent.
Hey, I got a question on the other, can you go back real quick? On some of these, there's like dashed out, like there's no,
That's a zero.
how come it's a zero?
Well, I'll take the state auditor fee, for example. We had not been charged fee. Our financials have to be audited, just like the county general fund financials have to be audited by an audit company. I used to be the state auditor, now it's a private company, I believe. Until 2026, our auditor had instructed us to budget zero for that expense, as that was paid from the general fund. In 2026, our auditor Brady Powers asked me to include an amount in the budget. So now you will see that that's not going to be zero anymore, and we'll pick up our share.
From 2027 on, that will not be blank?
I don't know about 2027. I'm still working on the budget. We can, either way, we're gonna budget, I'm just gonna have to get a guidance from the auditor's office on whether that we're gonna be paying a portion of that.
If that's the example you use, does that mean that we didn't get audited by the state, so you didn't have to budget for it?
We did get audited, not by the state,
Uh-huh.
but we did not have to pay for the audit. It was paid by the general fund.
Got it, thank you.
Yeah. Economic Assistance Department, Economic Assistance Team consists of one supervisor and 4 eligibility specialists who provide eligibility determination and revalidation reviews for many state and federal support programs, such as cash and food assistance, housing support, several healthcare programs, child care assistance, and process applications for emergency assistance and county-funded burial support. 2 case aid support provide direct support to this area as well. Child support services in Cook County are provided through a contract with Carleton County, and next slide is going to show the financials for the economic assistance team. The 2025 actual expenditures in economic assistance department were 96% of the budget, while the revenues were within 95% of the budget. The biggest variance can be seen in the client programs, resulting in 36% actual expenditures less than the budget and the corresponding decrease in federal and state revenues. The expenditures exceeded revenues by $16,234.
One question here from Administrator Treble.
Thank you. Plamen, can you explain the 64%? Is that down because client numbers are down?
Yes, next slide will go over that,
Okay.
or the slide over. I want to go through the personnel a little bit. You'll see that we're at 101%. And that is because we made a payment for our
Try to come back for the,
electronic health record software for both 2025 and 2026 and 2025. When we get an invoice, we have 30 days to pay it. I didn't feel comfortable waiting until sometime past the 30 days to get into the 2026. So that amount is a little bit over $18,000. So that puts us at 101%. And our expenditures exceeded the revenues by nearly that amount. So we essentially would have broken even on the economic assistance team, if you could say that, if we didn't pay the amount for electronic health record for 2026 back in 2025. Does that make sense? Okay. The funding sources for economic assistance team, federal and state funding made up to 53% of the revenue received from the economic assistance. That includes federal administrative aid, which supported some of the payroll cost of staff providing the eligibility services for state and federal programs, as well as reimbursement for county paid client assistance. Fees and recoveries made up 2% of the revenue. The county is required to perform collections on behalf of the state, and in return, the state allows us to keep a small portion. And the remainder of the funding came from county tax. So the federal and state funding is significant for economic assistance, especially the federal funding. It's nearly 50%. Just want to make a note of that.
And that's good.
yes.
Yeah,
Yeah,
it's
Commissioner,
not coming from a county tax, so.
Commissioner Gamble.
Thank you, Mr. Chair. Plamen, do you know, not like you got enough numbers to have to shuffle around and be mindful of, but do you know how this compares? Like when you look at the support, that if there's an allocation based upon population numbers or some other criteria, but when we look at how much of our tax base is supporting, these different departments, just how that compares. And the other thing is that when it comes to recovery and fees, if understanding what that is and how that
I can
compares.
explain to both, yeah. I remember going through a exercise of finding that information about neighboring counties and other counties during the budgeting process. I can't quite recall if that was the budget for 2025 or 2026. the goal was same, to determine how much of Public Health and Human Services Department as a whole and broken down is funded by county levy and from state and federal. And I remember that the numbers were very similar for the other counties too. But I could go back to those and try to recreate those numbers again for a more recent year. So I could do that. But I remember that we were not any different from the other counties. Our levy was somewhere less than 50%. In some instances, some counties had levy higher than 50%.
And sometimes that number, given our size, that that impacts how we reflect as opposed to other counties because of our population and the size of our county. The reason that it's helpful is it's sort of a checks and balances thing. So it's not like you're trying to put a lot of more work, on your shoulders, so to speak. But it is something that when you come before this body, that you can show that, and it's an indicator. And I know in my past experience in doing budgets that I would use comparables based upon regions and based upon total budgets and based upon the nature of similar activity. And those three components that in an annual meeting or for a board that's looking at that, they could look at those comparables and say, why are we so different? And so it was an accountability thing, so I appreciate it.
And I remember going through that exercise, and I will again. And I will say that we were not different than other counties. In fact, our county tax was less than 50%, which is good. But I'm going to also use this opportunity to say, well, I think looking back is important, and it's a good indicator where we at a certain time. But I am concerned that going forward, those numbers may not be the same, because we are seeing changes in the federal
Sure.
spending and in the state spending that I think we are sensing that the county share is going to increase.
Yeah. And it's just an assurance to the community when those numbers are seen and compared that says we're good stewards and we're doing a good job. If there's anomalies in that, then that's why people would question, but.
I have a slide here that I can show, maybe, I don't know if I can show it. I'll try. Comparing our numbers for county tax over the years.
Yeah.
I could do that at the end of the meeting here.
Sure.
I do want to go back to your question about recoveries. Those are the medical assistance Medicaid program recoveries. In order for state of Minnesota to participate in the Medicaid program, we are obligated to recover funds remaining in the state of a decedent after if they've received certain services during their lifetime. Now, while we may recover a significant amount of money at some point, we only retain a small percentage because of how the federal, state, and county share work. So the majority of the funds are reported. We report the funds to the state of Minnesota, and we get invoiced for those recoveries, and we have to pay back the majority of the funds.
Okay.
Other recoveries are under a food support program and other assistance program overpayments, whether those are due to household error or agency error, we are still obligated to make recoveries. But those, as you may imagine, those are small amounts because the assistance programs are not big in numbers to begin with. So we receive a very small percentage of revenue based on those recoveries. Same, we make a recovery, we report it to the state of Minnesota through our Maxis system. They send us an invoice, we pay it back.
Thank you for that context, appreciate it.
The next slide is going to show the new applications in 2025 for assistance programs compared to the 5-year average. Those numbers for food support are 96, healthcare 58, emergency assistance 24, cash assistance 16. total of 194 for 2025, where the prior 4-year average was, or 5-year average was 234. And then next slide is going to explain the question Administrator Kristen had about client programs. The cost-effective, so those are the 3 programs that are listed under financials. The cost-effective insurance, provided transportations, and Medicare Part B. Cost-effective insurance allows us, people to get reimbursement from the state of Minnesota if it's determined that their insurance they have with their employer or their whatever insurance they have is cost-effective to the state of Minnesota. In other words, it will cost less for the state of Minnesota to reimburse a person certain amount for their insurance premium versus if they were insured through a different insurance provided by the state. For those,
Crystal?
All right. And the other side, was there a decrease in the number of people?
correct,
Okay.
where we budgeted $117,000, we only had claims submitted to the county for $66,954. We receive 100% reimbursement. We have to go through a process of, again, entering those in the system, and then we get payment from the state of Minnesota throughout their biweekly payment cycle. So we're at 100% there. The provided transportation is the second item there. Allows community volunteer drivers to assist eligible elderly clients with medical rights. Public Health and Human Services direct bills and receives reimbursement from managed care organizations, with reimbursement rate varying depending on the loaded and unloaded mile and the managed care organization the client is enrolled with. The reimbursement amount was at 87% for those costs. We never expect those to be at 100% because managed care organizations do not cover the full cost of the travel. Reimburse at lower mileage in some instances and a higher in some other ones. So it's at the end of the day, we don't get 100% like we do it under cost-effective insurance. And the goal is to be somewhere near 90, which we're at 87%. The agency is currently pursuing a contract with Medica, one of the managed care organizations providing coverage in Cook County, with the goal to be able to submit claims for services provided to Medica enrollees. We are seeing that a lot of the members that were UCare members are now getting transitioned to Medica. We had an established billing procedure with UCare and with Blue Plus. Now we are working on establishing one with Medicare, so we can bill Medica, not Medicare, I apologize, for those services as well. But it's not as simplified process as with the cost-effective insurance, entering something in a system and receiving biweekly payment. You have to get credentialed, you have to enter in a contract with the managed care organization. There's some levels of work that needs to be done on the front end to begin billing for services, which we are actively engaged in. Healthcare access and Medicare Part B. We used to see costs here and reimbursement under a healthcare access program. We no longer administer that program because that has been transitioned to a company called MTM, Medical Transportation Management, I think it stands for. We could have a long conversation about MTM when we're hearing that there is a little bit of a hit and miss with the administration of the program, and the state is, correct me if I'm wrong, looking into alternative ways to administer the program going forward. But for us, what it means is we don't have to make payments to clients for travel, to medical appointments, and that's now handled by MTM. Therefore, we don't have reimbursements because we don't have any expenses to bill for. So these costs are only for Medicare Part B. Those are premiums that clients eligible for reimbursement from the state of Minnesota So we, as our economic assistance team determines that they're eligible, we make the payments to the client, submit billing to the state of Minnesota, we receive reimbursement. You see a higher, we have 102% because it's the timing of when the services are provided, payments were made, and the revenue was received. We just have a little bit more in this year. That likely included some services that were back in 2024, which the revenue came really just a little bit late after March. Any questions? As I mentioned earlier, the child support services are provided by contract with Carleton County. Which Carleton County provides the following: case intake and assessment, establishing paternity, locating absent parents, establishing and enforcing orders for child support or spousal support, collecting on current orders. There were 91 open cases in 2025. I think we're seeing a steady decline. I probably don't have any comment or knowledge of.
I can add that our counterpart in Carleton County, who administers this program on our behalf, will be joining us for the June PHHS board meeting to provide more information.
Why are we with different counties?
We contract out this service specifically because of, I believe, our small caseload and the amount of staffing expertise that it takes to run the program. So rather than hire someone who would have less than a full-time position here, we contract with Carleton County and they provide the service on behalf of Cook County families.
Commissioner Gamble?
Yeah, thank you, Mr. Chair. So when we track things and we graph things and we look at it, it's to inform us. And so in that context, when we look at the child support open cases, much like we have when we have, huge variables depending upon the numbers, again, with a small population, it can influence these graphs. But we can see the declining nature of it. What is it telling us?
Well, that's going to be a good question for me. What I'm looking at this, I'm saying, can we ask for reduction in the contract?
Yeah.
But I think that conversation.
Yeah, I think that would be a great question for, his name is Dan. He's going to be joining us in June, but I would defer to him on that question.
Okay.
On the other hand, I know that what we pay Carleton County for a contract equals paying for one FTE in public health and human services. So, and because of all the different things and challenges we have going on right now in public health and human services, I don't know that I would recommend bringing that in-house. But those questions are good for somebody who's an expert in the area, who will be Dan Plinsky. He's very knowledgeable.
Yeah.
What I know is I receive the performance results from the state of Minnesota, and we meet in all the requirements and above. And that the contract increased once during the time I have been with Public Health and Human Services by $3,000. And I thought, for the work they do for us and meeting all the requirements, I think that's money well spent. But this is a good question. I've been looking at the numbers going down, and actually Grace and I had that conversation. I mentioned to her when I have begun work for the 2027 budget, and with the smile on the face, I said, I'm kind of looking at asking for maybe decrease in a contract, but I don't know, we'll have to. Keeping a full-time person is probably not, it's probably for Carleton County, they're gonna argue back saying, well, we have to have a full-time person to do this work. So I don't know any more about that.
Yeah, and I'd say this is doing good work, and so we're asking, it's almost like getting paid less for doing better work sort of situation. So I'm a little leery of that, but it would be a good conversation to have. Administrator Treble.
Thank you, Chair. I would just say that instead of a decrease in the contract, perhaps we look at remaining steady with the contract, because most contracts for services are increasing over time. And so the decrease of clients is not significant, but enough where I think we could engage in some discussions about that.
Mr. Kemp?
Yeah, by my question, I wasn't implying that we should take it in-house. I think that, especially as a smaller county, that the more that we can partner with people that have the expertise, and we're going to be, talking about that with our crisis, mobile crisis as well, that we want to establish partnership with competent, capable, experienced individuals. How we draft that contract and what's normal in practice in that regard, if it's based upon a numerical assessment or if it's just simply a contract that says for services, whatever it is, this is our contract, we know what that is. When we look at out-of-home placement costs, that's a variable that's very hard to control. And so when it comes to budgeting, it's whatever we can do to clarify our budgets with a known figure is good when we have competent people that provide that service. In our leadership meeting the other night, our county attorney commented that they're bringing things in-house that we used to pay out for. And that is a good thing for the county, in the fact that many times the responsibilities that come underneath the county attorney, if we don't have the expertise or our workload is such, then we job it out. By bringing it in, it helps us control costs. It also increases our ability, our knowledge, and our experience to be better positioned for dealing with legal issues as a county. So that's an example where an assessment at some point says it's better for us to bring in-house, and we evaluate that. But by no means in my comment was I saying that we shouldn't cultivate healthy relationships with capable entities, but how a contract, when we see significant change in that regard relative, you think you're being paid based upon the amount of work. And if we see a declining number, then it doesn't hurt to have that conversation. But when it's a variable, you don't want to be changing every year, but you might over time change the basis under which a contract is written, as long as it's considered to be best practices in this particular area.
And I just want to make one comment. I think for Carleton County, keeping the contract at the same level over the years with a very small increase of $3,000, which is less than 1% or less than a couple percent. I think they have increased cost to have to keep their staff and to rent their building and to maintain things. So I think they're mindful of the fact. I've had conversations, pretty kind of base conversations with Dan Plinsky, and he told me, it costs us more every year to have staff. So for them to maintain the contract at the same level, that's a benefit for us too, and it seems to be working for them too. But I think that graph does say something, so I think it's good to, in the June's meeting, to get some more information. I think we're all going to benefit from that. The social services team, it's comprised of 3 teams, adult home and community-based services, children and family services, behavioral health team. The adult and home and community-based services team has 1 supervisor and 5 social workers, each with a different case management or care coordination specialization, providing adult protection, waiver case management, long-term services and supports, intellectual and developmental disability services, mean choices assessments, and 1 social services case aide who supports this team. The team also has several independent contractors who provide in-home support services to the aging population. The Children and Family Services team is the next column in social services. It's comprised of 1 supervisor. Currently, there is no supervisor to that team. And those responsibilities are performed by the adult home and community-based services supervisor, Olivia Bonander. 2 social workers providing child welfare and child protection services, family assessment response, and parent support outreach services, and 1 child care licensor. The social services case aide also provides support to this team as well. The behavioral health team with 1 supervisor and 2 social workers providing children's and adult mental health case management, substance use disorder treatment coordination. The social services CADA also provides support to this team. Contracted provider for this unit is the Wilderness Outpatient for comprehensive assessment, outpatient treatment, and inpatient substance use disorder referrals. For all 3 units of social services, costs were 3% over the budget, and the revenue received was 4% more than the budgeted amount. $200,000 of fund balance was budgeted. No fund balance was used, with the social services department returning $31,258 of fund balance, as the revenues exceeded the expenditures by that amount. As we're exploring options to restructure the department into 2026, several vacancies remain unfilled at year end during 2025. This led to a reduction in the personnel cost and associated federal and state aid. The biggest variances were under children and family services, including our home placement expenditures, exceeding the budget with 122% of the budget amount due to the number of children in our home placement remaining at the high level. There were 12 children in our home placement in 2025, 15 in 2024, 14 in 2023. The mental health services expenditures exceeded the budget with 208% of the budget amount, largely due to the adult mental health placement and state-operated mental health facilities for client care, with $47,296 expended. Children's mental health placement for a total of $80,539, and expenditures related to a mobile crisis response grant, which included electronic health record, contractual obligations with Brightwater, formerly HDC, for after hours and supervision, and other mobile crisis response grant related expenditures. Please note that the mobile crisis response expenditures are 100% reimbursable under the grant, so you'll see that on the revenue side too. Adult home and community-based services with 162% of the budget amount due to increased in-home support services for a sliding fee scale. You may remember that earlier this year, Olivia and Bonender and I requested the board approve a revised sliding fee scale and a cost-sharing program to increase the client cost share of the program expenditures and reduce the levy impact. Increased CADI, BI waiver services, those, however, are 100% reimbursable between the Medicaid program and the managed care. Between the Medicaid and the client obligation responsibility. We've also reestablished a process of billing clients for their waiver obligation and spend down amounts. While that's not a significant amount in the agency's budget, it's a requirement that we need to continue to do. And in order for those clients to continue to qualify for the programs and receive services. On the revenue side, children and family services, some increased funding under the Family First Prevention State Program. That was a fairly new program. Our allocation for 2025 was $10,000. Employment and trading increased revenue by 4%. The SED program, the substance use disorder, lower reimbursement revenue while we still learn how to use the electronic health record program implemented at the beginning of the year. And the mental health services reimbursement for a mobile crisis response grant, again for electronic health record, contractual obligation, and other mobile crisis response related expenditures. All in all, the revenues exceeded the expenditures, with the social services contributing back to the fund balance instead of using the budgeted amount. Any questions?
Mr. Campbell?
Yeah, thank you, Mr. Chair. Plamen, is the money that you recovered a significant amount of money? Is that in the 2026 budget, Or was that reflected in 2025?
That is reflected on the 2026's financials. It's not included here.
Yeah, thank you.
The recovery was made at the time that we could record it still into the previous year. However, those services provided were for a prior year and not 2025, so I couldn't allocate those to 2025. Instead, I put them in the current year of 2026.
Okay, thank you.
Social services, funding sources,
What year is this?
2025, I apologize. Federal and state aid made up 36% of funding for our social services revenue. Fees and recovery funded another 11. This is from billing, health insurance for client waiver services, care coordination, targeted case management. Small portion came from the other grants. I was explaining a little bit ago about adult, I'm sorry, I keep saying adult, but it's the Arrowhead Behavioral Health Initiative. My apologies. And the remainder came from a county tax at 50%. Some stats here for the social services team. That is the social services staff hours by program area for year 2025. The increase in the time recording, and particularly the program-related time, was identified as one of the main recommendations in the report prepared by Megan Moss and the Birch Bark Consulting. The agency has implemented guidelines and policies to assist in achieving higher percent of reported time and higher percentage of program-related time.
Crystal?
Can you give me an example of what a non-program related time is?
It would be a training, meeting. Sometimes our intake, when you're not responding to an actual intake and you're just on an intake while you're trying to manage some other tasks, there will be some non-program related time.
Mr. Campbell?
Yeah, thank you, Mr. Chair. This is an interesting graph to look at, but it is, because it's focused on 2025 from a department head standpoint. If I'm looking at this, I would look and I would say whenever both an allocation of dollars or time, I would compare this to see how this is using different years. So when I look at what 2024 is, what we're experiencing now as we monitor 2026 relative distribution of hours, it tells us something. If there's something that has changed in our environment, so to speak, I'm talking, if we're looking at hours, it helps us to be good stewards by making that comparison and evaluating, saying, oh my goodness, like I think if we look at the mental health, we're probably seeing a significant increase in hours. And we might also see that translated to dollars, but when we have change either on the state or the federal level, and we're looking at this graph in dollars, we can see the effects of that in overall budget analysis, which is really good information if you want to have evidence-based budgeting. You're looking at these figures and drawing conclusions based upon what you know is changing in the culture, the environment.
So I will say, this data comes from SSIS, and time reporting in SSIS was probably the biggest recommendation in Megan Moe's report. We do have a work group that's looking at making improvements to SSIS time entry. We are tracking the time entry practices by staff and meeting with staff to follow up on their time entry every month. So this is an area that we are tracking very closely. And we do have a small group within the department that's looking to make improvements. So.
Thank you.
Yeah, and it sounds like already there's been significant changes for 2026, and maybe we won't see quite the shift in numbers until 2027, but it'll be exciting to see.
The first thing you're going to see is a non-program related time. First of all, what you're going to see is more time reported in general. However, so I keep track of every month. The staff has until a certain period of time to report their time in SSS, Social Services Information System. Then I run those reports and put them in a spreadsheet and start comparing. So what we're seeing already in 2026 is that with less staff, we are on track to record significantly more time in general in SSS. The next goal for us is to decrease the non-program related time and increase the program related time.
Administrator.
Thank you, Mr. Chair. Plamen, can you talk briefly just about how tracking time impacts revenue?
So first, I'm going to start with the tangible ones right away. The more waiver case management, the more targeted case management, that's direct revenue for us. We get billing. We bill the state and the managed care organization based on time record staff enters in SSS. Those rates are, in some cases, significant, especially under the targeted case management. We get $500 in some instances per occurrence. So, and more time, more program-related time, direct correlation to increased revenue. Some of our grant allocations are based on time, program-related time reported in the Social Services Information System. It's an elaborate explanation and calculation that I'm not prepared to go over right now, but the program-related time is taken into consideration when money is allocated. So money right now, and money right now is a revenue from the services we receive. In the future, allocations are based on time reported now.
Thank you, Mr. Chair. Thank you, Plamen. And the reason I asked that question is because we anticipate, like Plamen has stated, that the cost share for the county is going to increase. What we're hearing is quite significantly over the next few years, potentially. And so it's really important that we're entering our time in SSIS so that we're collecting as much revenue as we can to offset that increase in the cost share as we're anticipating. So the team is working really hard on improving that, and like Plamen had mentioned, or Grace had mentioned, that was a recommendation from Ms. Mose as well.
Commissioner Gamble.
Yeah, so another way of understanding that, would that be that when we track our time and our time is reimbursable based upon a certain number of dollars, that if those dollars that we get reimbursed reduce, then it means that we have to be sure that we're tracking everything, because everything is going to matter when there's a reduction. So be sure that you're getting your time tracking correct, because there's no wiggle room there relative to the revenue. So, and I think that if I'm connecting the dots correctly here, that we received a letter of commendation saying that we're doing a good job of submitting our reports on time. And if the reports are reflective of what in fact is true, then we're doing the best we can relative to reimbursement.
So I believe that was regarding the letters from DHS that I mentioned in our last PHHS board meeting. That was for our fiscal team fiscal reporting. So they're slightly different.
Okay.
The fiscal team submits reports on a quarterly basis, and what we're talking about here is social service staff entering time in a software system.
Okay. Thank you.
So
Any
there,
more questions on that?
for the fiscal team, we're at 100%. And so for the
I don't know
time
that we're
recording, we're
100%,
working
but-
towards 100%.
We certainly try.
You're squirming.
Well, I mean, I think nobody's 100%.
Yeah.
Let's be honest.
All right, 99.999.
Okay.
You're doing a good job.
I'll take that. But back to the hours, and I don't want to overstretch that. I take what's in SSS. I cannot manufacture numbers or make numbers different than what's recorded by staff. So what I'm looking at is, I'll tell you what I'm doing right now is, I take at the end of every month the cumulative numbers that are entered in SSS, and I compare the difference between what was recorded at the end of March with what's recorded at the end of April. We look at what the percentage of non-program related time is versus the entire time. I make an adjustment for staff. Oh, that's a good explanation too. Paid leave, I shouldn't say paid leave. Paid time off is also entered by staff in SSS, but as a non-program related time. So I have to make that adjustment in SSS so we can see the true non-program related time that staff is reporting, because it wouldn't be fair to say, well, your paid time off is program related time, but it is not. So there is a lot of things that, but basically we're comparing, again, month to month, cumulative, what the percentage is for program related time, non-program related time, and also compare to E-time.
What?
In other words, to our
I missed what you said.
payroll recording. Each staff has to enter their work time in a system in which payroll uses to make payments to staff. So I compare those hours in SSS to the E-time hours. The E-time is the
E-time.
system, to see what percentage of those hours were entered in SSS. So I feel like on a fiscal side of things, I exploiting all the options that I have.
Is this printed somewhere? This, like, because what I'm seeing is this, but what I was given a link to doesn't match this. So is there a way where I can get what you're showing us on the screen?
I'll send up those slides.
Thanks.
The financial report should be included to
Yeah.
the agenda, yeah. And that should be included there too, but we could send,
Thank you.
when I say we, Erica will take it. Don't
Yeah,
want to
it's-
take any credits.
It's just a different format, I think.
Right.
Like, page 9 has that graphic, but it's smaller and.
All right,
Same info, okay.
oops, sorry. Public health team. This is the public health team with one supervisor, 4 public health educators to meet all 6 areas of Minnesota public health responsibility within the local Public Health Act. The public health team provided regional collaboration, grant writing, and contract management, emergency preparedness during the pandemic. The public health team played a major role in vaccine planning and implementation, case investigation and contract tracing, and liaison to the schools and businesses, as well as the coordination of many community volunteers, with a shift to building and maintaining infrastructure, promoting health activities and behaviors, and other prevention work post-pandemic. Using contracts with Southwood Mountain Clinic and North Shore Health, Cook County provides several additional public health programs, such as the home care sliding fee program, child and teen checkup, family home visiting, and WIC, women, infant, children. As a reminder, the SHIP program is fully administered by the Cook County Public Health and Human Services, while it was contracted with South Mountain Clinic in the past. The public health costs were at 95% of the budget. The revenue received was 8% more than the budgeted amount. No use of fund balance was budgeted. No fund balance was used, with the public health department returning $33,965 to the fund balance, as the revenues exceeded the expenditures by that amount. Note that revenue under the personnel line was at 120% due to the increased revenue from federal and state grants available to the public health team through the community health board. Any questions on that? Public health funding sources in 2025, 57% of the funding for public health came from the federal and state grants. That number was 52% in 2024. And less than 1% of them from non-governmental grants and donations, and the remaining 43% from county tax.
Sorry. This says including the public health grant.
Yes.
Is there a slide or a picture
Yes.
that shows What the,
The
okay.
recipients of the public health grant funds, yes.
Okay.
A couple of slides down. Next slide will show you the hours by areas of public health responsibility. For infrastructure, 35%, healthy communities, 50%, infectious disease, less than 1%, environmental health, 4%, preparing and responding to emergencies, that's 10%, assuring health services, 1%. This is a good example of time reporting. We moved to 100% time reporting with the public health team a few years ago when I became a fiscal supervisor. I met with Grace and I said, we need to move to 100% time reporting because we have grants that are available to us and we can utilize them. Grace agreed, and in 2025, we are returning to fund balance by $33,000. We're using more state and federal funds by 4% than the year prior. So it's a good example of how time reporting makes a difference. Any questions on that? The public health community grants are awarded to community organizations through a competitive annual grant-making process. $190,000 were awarded in the year 2025. As a reminder, the subcommittee of the Public Health Advisory Committee makes funding recommendations each year, which is presented to the Human Services Board. Grants are made in line with the goals set forth in the Community Health Improvement Plan. These represent areas of essential community service that would go unfilled without support through the grant-making fund. This is the list of the 2025 recipients of those public funds. Any questions on that?
Wait, sorry. Was there like a grant application? How did you determine?
There
who
was.
received-
So
there was-
every year there's a grant application. It typically opens sometime in June and then closes mid-July. And then there's a group of members of the advisory councils that has, we go through the application and there's a score sheet, and then that group of people scores the applications, and then brings recommendations to this board for a vote.
Understood. Also, my bad, I just got here today, so thanks for answering all my questions.
These are good questions.
Great question.
In 2026, we lowered that amount to $150,000, and I think without getting into, okay, Grace is saying I gotta keep moving forward. So basically in the 2027, my recommendation will be to keep it at $150,000 and not increase it. Yeah. All right, next slide is the child care program. Costs were at 98% of the budget, with the wage subsidy program utilizing 82% of the budget. Revenue received was 56% more than the budgeted amount. $366,645 of fund balance was budgeted, with the child care department using $204,876 of fund balance. As the expenditures exceeded the revenues by that amount. Note that the expenditures and revenues under the provider assistance line were both over 100%, 142 and 156 respectively, due to the increase in available state and other grants. So the wage subsidy is levy funded. The provider assistance and supplies is grant funded.
You said, wait, provider assistant is grant funded?
Yes, and supplies.
And then what, that's like the cost of the employees, and then what are the supplies?
So that provider assistance and supplies represents grants that we received from DEED to support the startup and expansion of childcare businesses. And then there's also 2 smaller grants to support providers. One is to a mentorship grant, and one was to support family, friends, and neighbors who provide childcare.
However, those grants will be ending in 2026, so we'll see a significant reduction of expenditures, or virtually no expenditures and no revenues.
I imagine a
Except for
lot of
the-
grants are ending, correct?
Not a lot of grants. no.
Is that gonna impact our county, or, you can tell me later?
I would
think
say
that's good
that
for 20,
There's grants that we receive that are competitive, so the landscape for applying to competitive funds has definitely changed. But then there are grants that we receive year upon year, and they're sometimes referred to as block grants, so that hasn't changed markedly. So it's a little bit of a mix.
And overall, all departments that make up the public health and human services saw increase of actual expenditures and increase in revenue. This resulted in $155,887 use of fund balance, while $566,645 was budgeted, or we used $410,758 less than what we budgeted. The total unrestricted fund balance as of December 31st, 2025 is $3,125,945. On the next slide, I'm going to explain what the fund balance is. Because county operations rely on property tax levy, the Office of the State Auditor requires us to hold reserve account that is no less than 5 months of the budgeted and operating costs. 5 divided by 12 equals 42%. This requirement allows the county to maintain operations during the first 5 months of the year before the first half of the property tax collections arrive in May and are distributed to the departments. A healthy fund balance also allows the county to fund unbudgeted expenses that arise and after the budget has been set. The county recommended fund balance for public health and human services is 42%, and the general fund target is 75%. The next slide here, the blue is the budget, in green the available reserves that PHHS has currently, and the 42% is recommended. So the green bar should always be higher than the red bar. To know how much to keep in reserves, we look at our annual budget. Again, the blue bars represent the annual budget going back to 2021. The red bars represent 42% of that budget, which is how much PHHS must hold in reserves to meet the first 5 months of expenses. The green bars indicate the actual amount of public health and human services reserves for each of those budgeted years. It wasn't all that long ago when our fund balance fell below the state required minimum. I remember that. However, in years 2021 and 2022, due to the increase in plant expenditures and an increase in third-party billing efforts, we had recorded an excess of revenue over cost, resulting in return to the fund balance. I mean, you'll see the green bars getting, in one instance, higher than the budget amount. So we had a fund balance higher than the budget. We began using some of that fund balance with budgeting $566,000 between year 2023 and 2024. In 2025, we also budgeted $566,000 of reserve funds in the event of unbudgeted out-of-home placement and the child care subsidy grants. While PHHS still has a healthy fund balance in against the barest required minimum reserves, it was my recommendation to the PHHS board that the 2026 budget does not include any fund balance, and it will be my recommendation in 2027 as well. There is some level of uncertainty that I think we need to be more conservative.
Mr. Campbell.
Thank you, Mr. Chair. So I'm assuming that the fund balance is invested like our county fund balance is, so that there's a return on that investment. Is that correct?
I don't have the answer to that. I believe no, because I would have seen an interest or any income coming. And ours, whatever we spent, at the beginning of the fund balance, whatever our revenue expenditures are under or over, the end of the fund balance is the difference between both. So I don't see, our auditor doesn't tell me add $1 million of interest because we got invested the money. So I believe the answer is no.
Okay. I mean, that's interesting to me from the standpoint of if there's a state statute or a recommended best practice that prohibits investment of fund dollars in public health and human services or not, that would be a question to ask. The other thing is, if you look at the return on investment that we have in our county fund balance, that certainly if we have the ability to keep the fluidity, the liquidity of those dollars and yet be earning money on that money, that would seem to be logical. In the recent leadership meeting, there was a discussion about endowments and trust funds, which, of course, there's different entities within the county that are looking at that. And even years ago, it was suggested that if we don't look at this revenue source from the standpoint of trusts or endowments, we're going to be in a position vulnerable because of the lack of funding through the tax and spend model. And so that would be a question I guess I would ask is, can we take those fund balance while maintaining the liquidity and yet be earning money on that money? Which speaks to the fact that if we have an endowment or a trust fund, it is contributing to try to lessen the burden that, as a result, falls on the levy, so to speak.
Yeah, it's a good question. I don't have access to the bank account for Public Health and Human Services. My role is just to account
Yeah,
for the
yeah.
expenditures
I guess
and
that's
revenues, but I
a
can
question I
certainly
would
ask
ask Brady or find out about, but.
Commissioner Sullivan.
Thank you, Mr. Chair. From a quick search with that question, it says PHHS funds allocated to a county, tribal nation, or state agency in Minnesota may not be privately invested in financial markets. They are public, strictly regulated operational grants and subsidies that must be used to provide direct public service, cover administrative costs, and run specific county programs. So
And
that's just a real quick search
And that's speaking directly to fund balances?
to fund balance in Minnesota. Correct.
Interesting.
Administrative trouble.
Thank you, Mr. Chair. I have sent a message to Auditor Powers as well, so hopefully we'll get a response from him, and then we can perhaps report out at the next meeting.
And I think the Magic Fund is a public fund, not a private, and so that's where our fund balance, the general fund balance is. And well, what do I know? But I'd be surprised if the PHHS fund balance wasn't wrapped up in that, just accounted differently.
Yeah.
So,
the
so
other
it goes to
thing-
any interest would go to the general fund.
Yeah, yeah. And the other thing is that when we're looking at this, especially in the budget process and following that leadership meeting, which is county leadership monthly gets together for the public and discuss issues, and we were discussing childcare at the last meeting, and part of the recommendation is we should be looking at an endowment, and it goes back to recommendations that I've heard relative to finding new funding mechanisms. The thing that's attractive about that, and did contact Extension Service yesterday to ask that they forward the information on the gentleman they made the presentation to Extension so that they could make that presentation to the leadership group. That if people believe in a particular service, they can give that money voluntarily to establish a fund that then funds those services. And that model is a good model because it is people who share the value or the worth of something that contribute voluntarily. Yeah.
And we have some of those funds in PHHS. However, they are restricted funds and not unrestricted.
Sure.
So they have a specific purpose that can be used for. One example was the McKnight Fund, and we have some other smaller funds too, the Heart Fund. But they again have very specific purposes that can be used for. And what you're seeing here as the unrestricted PHSS fund balance can be used for any reason to deliver the services, while the other ones can't.
And I understand the nature of restricted funds, but what's good about that is if you look at the difference between levy and between endowments or trusts, is that people give their money to something that they specifically believe in, and those dollars are restricted for that provision or that, service that's provided. And so as opposed to when we levy, there's multiple things. Some people believe it and some people don't, but the levy is the levy. And so I would agree, this is, when we're looking at fewer dollars and more services, which we hear every year, we need to look for new ways of trying to fund these things, and that certainly is an option.
I just wanted to explain what unrestricted PHHS fund meant for those who don't have a good understanding, so. That is the financial report for 2025, our budget to actual financials. Any questions?
Can I ask you a question about the slide before this?
I'm sorry.
Can I ask you a question about the slide before this? When I
Yes.
look at this, it looks like in 2026, that if this continues, we're gonna have a problem going into our reserves in 2027.
That's why I recommended in 2026 to the Public Health and Human Services Board that we do not use fund balance and we reserve all the funds we can, so we don't run into that situation.
Oh, so the recommendation's already been made?
Oh, yeah, the 2026 budget has been approved.
Yeah.
And I'm going to make the same recommendation for 2027. We do not use from the fund balance. We only used from fund balance in 2022, 2023, 2024, and 2025, because if you see in 2022 and 2023, our fund balance was too high, almost.
Right.
It was higher than the budget, so we would levy funds while we would, we reduced the levy impact by reducing the requested levy by using some of our reserves.
I see.
That makes sense?
Yep, makes sense. Thank you.
And Commissioner Gamble had a question too.
Yeah, it wasn't a question, it's just a comment. I really appreciate your work and walking us through this, the detail, and the ability to respond to questions. It built confidence, and if I could borrow a phrase from the insurance industry, I would say we're in good hands with Plamen.
Thank you. Well, thank you, if I may. I appreciate the comment. I just want to say that we have a lot of good staff doing a great work in PHHS, and what I'm doing here is presenting the work done by many others. So while I appreciate the comment, I think it's a testament to all the work that everyone else is doing too. So thank you.
Thank you.
Thank you, Plamen.
Sorry about taking some extra time.
No, that's just
That was
fine.
all of our questions.
It's our
That's-
questions.
Yes.
No, you're bad.
Surprise.
Excellent. Thank you again, Plamen. And just for everyone's awareness, our next item is the mobile crisis response proposal. So we'll do a little shuffling and we can move on to that.
Wonderful. Well, thank you so much, Plamen, for your presentation on the 2025 financials and for all your work in compiling accurate data year upon year so we can see trends and also detail as to where the financial picture is for our department. I appreciate it. I will welcome Cree. Cree Larson is the Executive Director of First Call for Help. First Call for Help, Cree and I will be co-presenting today on mobile crisis, and at the end of the presentation, we will be making a request of the board that First Call for Help become the provider of record for mobile crisis response in Cook County. So, sure, I'll take the little clicker. We do have a brief PowerPoint to get us started. So I wanted to, I know that the PHHS board has heard about mobile crisis year upon year, and I do want to make sure that we just kind of ground back into the basics of what the service is, the importance of the service, how we're currently delivering services in the community, and who our partners are in administering mobile crisis locally. So mobile crisis are trained teams that provide 24/7 response and services to individuals experiencing a mental health crisis. This could be in their homes, in the community, or in other sites outside of the usual clinical setting. Mobile crisis teams can address and resolve mental health emergencies, cope with immediate stressors and suicidal ideations, identify and use client strengths and available resources, work with individuals, families, and providers to address immediate needs, develop action plans and connect to needed services, and begin to support clients in returning to their baseline level of functioning. Why is mobile crisis important? I will mention before I go into the importance that it is a statutorily required service. So throughout the state of Minnesota, mobile crisis providers must be either a county board operated entity or a provider under contract with the county board in the county where the service is provided. Why is it important in a more global sense? It can prevent situations from escalating into emergencies that require hospitalization or law enforcement. It's a vital piece of an integrated mental health system, and it's also a connection to ongoing support to provide stabilization and a link to additional resources to help address root causes and long-term recovery for clients. It's not a service that's ever provided in isolation. So this type of work requires a village, and in our case, that village is both local and regional. We work currently with Brightwater Health, formerly HDC, to provide clinical supervision to our mobile crisis responder, who's sitting right there, Sarah Eisenreich. They also provide after hours and weekend coverage for mobile crisis, so it is a 24/7 service, and what we have right now is we have staffing during business hours Monday through Thursday. So those other times we have Brightwater helping us to respond via telehealth. First Call for Help, we're about to hear much more about First Call for Help, but they do currently work with us in that they are the regional 988 call center. So when crisis calls come through, they come through First Call for Help, and then they are transferring those calls to our local responder or Brightwater, depending on when the call comes in. The Arrowhead Behavioral Health Initiative is a regional joint powers focused on behavioral health services. Some of the grant funds for this work are coming to us through the ABHI, and they also provide sort of a community of practice for regional behavioral health staff. Locally, we have Sawtooth Mountain Clinic, Grand Portage Human Services, North Shore Health, and the Cook County Sheriff's Office, who are all important partners in the work. We do have a local coordinated crisis response team that meets to improve our workflows and support one another in developing a robust mobile crisis system locally. So this service has been provided in-house. It came to us as a pilot coming out of the pandemic. And at that point, Cook County PHHS opted to administer daytime mobile crisis services here in-house. We have experienced challenges, and those have included building up that programmatic infrastructure to meet licensing standards from DHS. There are stringent requirements that the state sets forth as to what it means to be a licensed provider of mobile crisis response services. And I will give a huge shout out to Andrea Orest, who's done an incredible amount of work in making sure that we're meeting all of those requirements within our department. Staffing the program, we are very fortunate to have Sarah here with us. Andrea has also served as a responder in the past, but it is a challenge to staff a 24/7, 365 service with the staff we have in our department. And part of that is balancing mobile crisis with the multiple other programs that we operate within PHHS. So I've already spoken to what our current service model looks like. We have a 0.8 FTE staff providing services Monday through Thursday during regular business hours, and that can be an in-person response. And then the clinical supervision, backup, and after-hours mobile crisis response coverage is contracted through Brightwater, and that would be via phone or telehealth.
So real quick, so staff works Monday through Thursday, and then on the weekend it's someone else, so like on Friday to Sunday it's someone else?
It's through Brightwater, so we don't have a staff person within our department that's on call outside of that Monday through Thursday time. So you can still call and you receive service, but you receive service through telehealth because the staffing at Brightwater is staffed out of their Duluth office. So that's how the service is provided, and we've applied for an alternative response.
How did you come up with that? That seems like it's,
The way that we've come up with that is really, we do understand that having an in-person response is always the preferred option, but we haven't been able to staff outside of the 32 hours a week that we have right now.
but why was it Monday through Thursday and not like Friday through, like, why isn't the person where crisis is more likely to happen? Because no services are open, but it's like it's on days that everything else is open.
We've had the staffing that we have been able to find and to incorporate within, the schedule that we have. So, I mean, I think it would be ideal to have, weekend in-person coverage, overnight in-person coverage, but we just have not found staffing to support that. So that's kind of where we're at with it. So we've been able to be creative and work with Brightwater to help us provide some services, even though they are not always in person at this point. So this is sort of what we're looking towards when we look towards the future. So First Call for Help put together a proposal to become the provider of record. What that means is that they would be administering all the licensed mobile crisis response services on behalf of Cook County. So we do have grant funds right now that are covering our expenses, and with this proposal, some of those grant funds would transfer over to First Call for Help. So we would no longer be receiving all of the revenues we're receiving now, but we would also no longer be incurring the expenditures that go along with providing the mobile crisis response services. We would, however, remain a supportive partner. I think we're all very invested in seeing this service succeed. And so we would help First Call for Help build upon the foundation that we've created and the partnerships that we've fostered over the past several years. So that they would be successful in administering the service. I think this would be a beneficial model because First Call for Help, as you will hear, they have extensive programmatic expertise and could provide oversight to a critical behavioral health service in the community. The plan is also for them to directly employ locally based responders with the goal of providing that in-person response whenever possible. And internally, this would allow us within PHHS to focus our efforts on strengthening the additional program areas that we are providing to the community. At this point, we are the only county in the Arrowhead that's directly providing the service in-house, and that was a choice, and it's also a reflection of the behavioral health landscape here locally. So Brightwater, for example, is providing mobile crisis response services for much of St. Louis and Lake counties. And while we are in the service area, we are also 2.5 hours away. So there are challenges just based on our geography and the providers that administer this service regionally. So this would bring us in line with other counties in the region and also leverage that programmatic expertise that First Call for Help brings. So with that, I want to turn it over to Larson to introduce herself and speak a bit more of the proposal that First Call for Help has put forth.
Okay. Thank you for having me. It was a stunning drive up here again. I enjoy coming up. I'm Larson from First Call for Help. I'm the executive director of that agency, and we have been doing information referral, resourcing, and crisis since 1974. We were one of the two very first crisis teams in the state. We opened ours in 1999, well before the governor challenge in 2010 understood the importance of that evidence-based practice model. So we've had many years ahead of time to hit some bumps and remedy them and figure out how to best serve rural northern Minnesota. I thought Itasca County was rural. You're vastly more rural than us. And so one of the things that that I wanted to bring forward about our proposal is that our crisis lines answer 988 for the entire state. We answer the farmer's distress line for the entire state. And the other side of the lines are crisis lines, direct crisis lines like the ABHI. We answer 47 counties for that. So I have the privilege to have like a bird's eye view over how many teams have solved problems so that we don't need to recreate any wheel. There's many teams that have had bits and pieces of things that I think could serve Cook County well. The model that we're proposing for you is much like Clearwater and Lake of the Woods. So Lake of the Woods is vastly remote in how they're trying to do services. And they locate residents who live in the county and train them to be part of the response team in the location in which they live. From a view of our county, I believe every county has individuals that live within the county that are passionate. They want to help. They want to be a part of the resolve. They want to be a part of decreasing suicides in their county. And they come with some skills, maybe some personal experience, and are able to be trained to do that. And so that's what we're proposing for Cook County. One of the reasons Itasca County and every other county in the region actually has pulled away from counties providing the service is that overload of tasks on top of the public health. Sometimes some of the union contracts are a rub, and that is problematic to budgeting and many other things. And that is certainly not a slam to unions at all meant that way, but it can accidentally rub. And so contracting with us, we're able to break down those barriers, not only with county individuals that might want to work after hours, and contracting with us, they're able to do while they're still a county worker, or faith members, faith community members, local advisory council members, peers in our communities that are able to be trained to do this work. So Clearwater's entity, their program, we default to that during storms. So we have individuals on our team, we have a team of 30 that they live in different parts of our county. They might be up in Effie and Big Fork, which is our most remote. They could be in Nashwauk, closer to St. Louis. And they agree to be paged out when there's a crisis closest to them, so that it's a quick response. It's a face-to-face response, which I believe is always the best response if it's safe to respond. I believe in telehealth when we can't get to somebody, but face-to-face response to do a risk assessment, to de-escalate, to put safety measures in place, to really determine what's the best placement or supports for this individual. And using that Clearwater, Lake of the Woods model, I think could be beneficial for your county. And that really takes on the role of myself and Isla and our team to work with all of the contacts that you guys have already built with Andrea and Grace. Like, the foundation is perfect for this work. I think our role is to come in and just do the lift to get it up off the ground. And so reaching out to all the townships, having township meetings, district meetings, organizational meetings with churches, and dig down and see who is really wanting to be a part of the solution in your county, and capturing them as assets, training them to be responders. On my team, I have 30, and I can tell you every single person on our team, we've had experiences with mental health, including myself. And that brings another level of caring and compassion and desire and dedication to a team, especially when you yourself have been in a dark time or a family member has been, and you want to be there for another family. And so the community and county-wide assets are going to be core to making this, this lift successful.
Thank you.
Okay.
Yeah, Commissioner Storlie.
Thank you. Thank you for the presentation. I attended at our emergency management meeting, a presentation also. So basically, we dial 988 if we're in an emergency. Is that the number? Who do we dial?
So
That is
not-
one way.
Yeah, that is one way. The ABHI, our Arrowhead region, has a crisis line number that comes directly to us to triage and dispatch out mobile crisis. If someone dials 988, that call will get to a mobile crisis team, but in a different way. So we're a 988 call center. So if someone doesn't know your local number, you can dial the 3 digits of 988. And we do a risk assessment and determine where's the correct service or resource this person needs. And when does it indicate it's a high enough risk to dispatch out mobile crisis. So that's one way to get to mobile crisis. But another effective way to get to mobile crisis is by using the local crisis line number, because that number lets the team decide what level of risk they want to respond to. It could be a medium risk where someone's having thoughts of wanting to harm themselves, but not a plan. They haven't had any history, but they're in emotional distress. And callers get to determine their own crisis. It could be that a pet passed away. That wouldn't be a response to stabilize a mental health that if you called into 988, it would result in a mobile crisis. But if you call into your crisis line, the crisis team build gets to decide what they're responding to.
So what I'm getting at is, what is the number? What is our local number then?
Oh, you
I'll have Andrea. Well, sorry, Andrea.
I should know it by heart, but we answer.
988 is so easy.
988 is so
Yeah.
easy.
It is.
Typically, when we give public presentations, we give 988 as the number because it's easy and memorable. And we do use the ABHI regional crisis line primarily with partners. So if a partner agency like the clinic, for example, wanted to make a call, they would have that more direct route. So
Okay.
I would say for now, 988.
988, okay, good. So
And
then my
that'll be
next
like
question.
oh, there.
Do you want the number?
Yeah.
Yeah.
So it's 844-772-4724, and that is the number that we put out. We made mobile crisis response business cards for Cook County, and that's the number that we put on the card because that is also the number that Brightwater currently advertises for mobile crisis, so it's always the same. But in the end, 988 is an easier number to remember.
And I'll also say within this proposal, there's no change in getting to the service. So for a member of the public who might be looking for mobile crisis response, the numbers stay the same. Nothing changes with that in this proposal.
We'll just do better, not better, enhanced education to make sure that families know what your access is. And it's really meant to be a no wrong door. No
Then-
wrong door to
If I may continue on. So my understanding is that all the local folks here could step up and be trained. I don't know, how would I handle something? Something's having, a very bad day, I could probably talk them through a certain step. So the training would be really in-depth so that I could handle someone who's ready to jump off a bridge? How deep
Yeah.
does this go for the training?
The training is upfront and then ongoing. So we really
Okay.
have a very tight clinical supervision program where we meet weekly
Okay.
with, like, my team in Itasca County. We meet every Wednesday, 7 a.m. to 9. And that's where we get additional information. We talk about a call that maybe happened. So in case that person might have been at home for the first time they needed the crisis, but the next time it's at the grocery store, and it might be closer for someone else to respond, that we know the best means to help stabilize that individual. And so the training's in depth, the clinical supervision is amazing, and then the one-on-one is as well.
And I'll also add that there's a component to community mental health trainings that is separate from mobile crisis and will be retained in-house. So Andrea is trained as a trainer for things like psychological first aid, or recently a COMET program, changing our mental and emotional trajectory. We've also done work to train local trainers for things like mental health first aid. So those offerings will stay in the community. And that would be for someone who maybe isn't interested in going the full, I want to train in as a mobile crisis responder, but wants to know how to better help a friend or family member dealing with mental health challenges. So it's a both and there are multiple ways that we can train community members, but what CRE's offering is really a much more intensive kind of package of training for someone who would take on that level of response.
Any other questions right now?
I just have a
Please,
comment
Ranna.
that
Yeah.
as a retired social worker, there probably, I'm not the only one in the community, people who have had experience might volunteer for something like that.
And they're actually paid positions.
Huh?
Because this is a lot. And I think too, volunteers are amazing, and they do a heavy lift at my agency, but not in mobile crisis. Because it's serious, it's intense, your time and your experience is worth, has a monetary value to it. And I think when you're paying someone to do it, there's that commitment of, yep, these are the days that I'm going to be available, and then you're contracted to be available. Yeah.
Commissioner Storlie? Yeah.
So I have another comment. I have townships, and you mentioned townships. So I go out there and I give a little bit of a presentation. And then they say, I'll get in touch with me, who will get in touch with Grace, or vice versa. How does all that work out then? We get some names of people. Is there a time schedule that you would do some training if you had two people, one person?
Absolutely. We
Okay.
would come up and train one individual.
Okay.
Every single person's going to be important. And I think that first visiting with them about really what is it you're getting ready to bite off. I think being upfront is better than sugarcoating something and then having someone walk into something that's then traumatizing for them. And so having a great discussion about the onboarding and what it is, what the training is, how we support them, what that looks like managing personal life around being a part of a mobile team, and then doing the training.
Do you have CPS on this board?
I'm so sorry.
Do you have CPS workers in this board, on this call in your
First call
county?
for help for child protection, is that?
Right, so certified peer specialists?
Oh.
Yes.
Thanks.
Yes.
You have them? Do we have them in this county or on your county?
We have them in my county, but in this proposal, we put in money to train PRS and PSS to make sure that if you're wanting to be a part of the team, you can become a peer recovery coach, a peer support specialist. Those are so important. And so built into this proposal is to build up that level of infrastructure underneath the team.
Okay, thanks.
Thank you.
Administrator Treble has a question.
Thank you, Mr. Chair. I almost said Madam Chair. I just wanted to mention again our report from Ms. Mose and Mr. Lee. They had provided some feedback about our mobile crisis team and just looking at different ways to provide this really important and essential service for the community. So I want to thank our PHHS team and thank CRE for the work that you've done to really investigate and put together a very solid proposal on what this could look like for our community members. So just thank you.
Commissioner Gamble?
Yeah. Thank you, Cree. We had this presentation at our Public Health Human Service Advisory Board, and one question I would have would be your business model. So if we were to look at a visual, which this morning we had a lot of visuals, that sort of breaks it out so visually we can understand how it works, mobile crisis. That first call for help, when somebody calls, it's like, who are they going to reach? And then when it's at the local level, if somebody is then dispatched, we'll say, to work with somebody. But can you give us your model as to how a response is handled
Okay.
to an inquiry?
Sure. So if someone calls into the crisis line, we have trained counselors that will triage. And so each mobile crisis that we dispatch out has a triage of what they can take. If it is absolute urgency, that is someone who's in the process of ending their own life or making an attempt to do it. That's like a 911 call if the scene's unsafe. If they are at high risk, saying, I have a plan, but I'm calling for help because I don't want to follow through with that plan, that would then get mobile dispatch out. So when you sit in my call center, it's almost like you're sitting in a little cockpit of 4 computer screens. And when the line rings, we know exactly the region or crisis line that's calling. It pops up the protocols, the resources, a call log, and emergency services, all at once, automatically. And so if we determine that in Cook County, a resident called in, they're at moderate or high risk, which I think both of those should get an in-person response, especially when you're introducing a team to a county, we would then, on the left screen, shows exactly who's available for page out, their number, and those are the individuals that are paged out to respond. Once they're paged out, we are able to, off of their cell phone, track them for safety to make sure that they're getting to the location and that we do a safety call 60 minutes after they're there to make sure everything's okay, because it can be scary in a remote community. And you might think you're responding to one thing on the phone, but when you get there, it could very well be something different. We do follow-up calls 30 or 60 minutes. The responder tells us which they prefer. If they do not respond to that check, we'll do one more time. If they don't, law enforcement is set out immediately, just to protect everybody. When teams are first starting out, we like to try to send 2 people at a time, and that's really going to depend on how quickly we can build up. So if we have 2 individuals living here, the crisis is here, we'll send both. I think 2 eyes are better than 1 always. There's safety measures in that, and hopefully there's comfort in the person being responded to, that it's really not law enforcement, it's someone trained in mental health. We then, as soon as someone's done with the response, we ask them to call back into the center and let us know they're done. And then on a computer screen, we watch their vehicles or their cell phones leave the residence. And then we know, okay, scene is safe and clear. Those responses are how that process works. Last year we answered 95,026 calls. Last year.
State or the county?
I'm sorry, excuse me.
State or county?
The state.
Okay.
And so it's a pretty hammered out, methodical practice of how people are screened, dispatched, and then the follow-up services. Was that what you were looking for in a description of how, or not? Did I miss the mark?
Yeah, I think when we're evaluating this whole mobile crisis and who we've partnership with, when we do that evaluation, we've seen some nuance, some things that help inform us as to what's most effective. First call for help originated in 1974. So, you've got half a century of experience, and you're dealing with 47 counties. So in your presentation, we see that this is something that counties are availing themselves of because it works, because we have experienced people, and your model says this is how it operates, and this brings integrity to what the service is that you're providing. So all of those things are very important components. So when you're making a decision, which we as decision makers are making today, it's going to be based on what is the service that you provide, how do you do it, what's your reputation, how much experience do you have, and the credibility that reinforces what you do, I think is demonstrated by 47 counties throughout the state that chooses to use the services that you provide. So that's the assessment of the value of what you do, and we've had some experience that has showed us where we maybe are vulnerable in some areas, and so we're looking for another option in that regard. The other component is the cost component. And so if we look at the value we get for the dollar expense, I guess if you could just speak to the cost component of this.
Sure. So we have 2 grants that currently fund mobile crisis work in Cook County. One of them is administered through the ABHI, the Arrowhead Behavioral Health Initiative. And with this proposal, the funds that we're receiving through that grant would, rather than come to Cook County, they would go to First Call for Help. So there would not be impact to our financials because both the revenues and the expenditures would be going through First Call for Help rather than Cook County PHHS.
Okay, Mr. Chair, as a follow-up. So we have grant monies that are going to fund this service. Anything on the horizon that tells us what the future will be relative to the funding?
There is a grant that's open for the next 2-year period, and that grant will, again, be applied for through the ABHI. So the funding is available for this next 2-year period, and the grant period's open now. So I know that our ABHI director is working on that application, and that in that application, the recipient of awards for Cook County would instead go to First Call for Help.
Okay. And I would say that based upon the discussions, the presentations we had both at the advisory committee and before us now, and evidently emergency management, that there's a proven track record. I think the number of calls that you take demonstrates that you have the experience with considerable volume, and that there is an accountability and a follow-up that brings integrity to that. I think that in the presentation that was made before the advisory committee, that the number of counties that you serve and the years of experience are what's, bringing confidence to a decision that would support that we would do that. And having said that, I'd be willing to make a motion, the motion that's before us, that the Public Health and Human Services Board approve the proposal for First Call for Help to become the provider of record for mobile crisis response in Cook County, in addition to the language that also appears in this motion.
Thank you, Commissioner Gavel. We have a motion. Is there support?
Support.
Thank you, Commissioner Sullivan. I have a motion and support. Any further discussion? Commissioner Sullivan, was that for the, okay, yep.
I was going to make a
For action,
motion,
yeah.
so.
Crystal, did you have anything you want, question? No. I saw movement. Oh.
Yeah, I was thinking of something.
Oh, okay. All right. All those in favor?
Aye.
Aye. Those opposed?
I'm just going to abstain.
Okay.
Thanks.
Motion passes. All ayes and 1 abstention. Thank you, Cree.
Thank you so much, Cree, for being here and for your proposal and your presentation this morning.
Wonderful. Thank you. And we'll work to keep the commission, each of you, knowledgeable about what's going on, getting feedback, because cookie cutter services from one county don't
Sure.
cover other counties. So we'll morph the process and the structure as we go. And thank you for your time.
Appreciate it.
Thank you so much.
Yeah.
Thank you, Sarah.
Do you have a brochure before you leave? Cree, do you have a brochure?
I didn't bring one.
Okay, no worries.
Yeah.
I appreciate
Can
seeing you.
access a website, is there?
Firstcall211.net.
Yeah. I just wanted to know if you had some.
Physical,
Print works better for me. You're good. Thanks.
Take care, thank you. All right, that moves us on to our director's report. We got 4 minutes.
Okay. I'll try to be quick here. And I have to apologize, I'm getting over a cold, so if I sound a little off, that's why. Okay, HR updates. We have 2 currently posted positions for adult mental health case managers. We accepted the resignation of Sarah Dregswick, behavioral health supervisor, whose last day was May 11th. And I am beginning to look at the recommendation from Megan Moe's report related to organizational structure, and will plan to give a more detailed update at the June PHHS board meeting. I've been creating a tracking tool that details the status of where we're at with implementation of the various recommendation in Megan Moe's report. The tool should be complete in the coming month, and I'll continue to share progress updates with the PHHS board at our monthly meetings. The PHHS Advisory Council and Local Mental Health Advisory Council will have a joint meeting on June 9th. We'll be reviewing the mission, vision, and bylaws of each group alongside the relevant statutes that guide our councils, and we'll be voting on whether to merge or keep separate the councils going forward. Also related to our advisory councils, I'd like to publicly thank Jerry Lilja for his many years of dedicated service to both the PHHS and local mental health advisory councils. Jerry has stepped back from service on these councils as he enters a new chapter in his life. So thank you to Jerry. Thrive Together, the online Cook County resource guide, is on track to launch within the next month. We will plan to share the site with the partners listed on the site first, and then publicly launch the site with a media release in 3 to 4 weeks. Historically, PHHS has used a combination of grant-based and donated funds to purchase gas cards from Circle K, previously Holiday. These were given to clients in need per the discretion of our intake and social services staff. We learned this past month that Circle K is no longer issuing gas cards. We still have cards on hand, but once they are gone, we will not have the ability to purchase more. Instead, we're exploring the logistics of opening a charge account with Circle K in order to assist clients as needed, and continuing to maximize the use of the MTM programs for clients on medical assistance for non-emergency medical transportation.
This county has had gas cards, but they choose who to give them to.
The gas cards are, the way to access gas cards right now is through intake and social services. So for clients who are who have a case manager with the department, they're able to access gas cards through working with their case manager.
Okay, thank you.
Mm-hmm. And then finally, I'm just now getting updates from the end of the legislative session related to the work that we do within PHHS. Like, during this meeting, I was receiving email updates. So I don't have anything to share yet, but I will plan to share more at the June meeting related to what the end of the legislative session will mean for PHHS work going forward. And that is it for the director's report.
Questions for Grace? All right, well, we have 30 seconds for our committee reports. So I think I guess I open it up if someone has something that they think needs sharing.
I could just say quickly
Please,
that
yeah.
the public health meeting was totally talking about what we just saw, so that was there's
Okay.
nothing new there. We covered it.
We've done some updates this past Tuesday too, so.
Just quickly say that our administrator was able to attend the Arrowhead Corrections Board meeting and took a tour, and then headed off to Wisconsin on a busy, busy day, but it's always good when we have context and understand the organizations that provide services for us from the administrative perspective, so.
All right, thank you for going. All right, well, with that, we're gonna move on to item 7, which is adjournment. We are adjourned. Thank you.
Knee surgery on June 8th.
Okay. Good luck.
Yeah, thanks. My last job.
Yeah? Have you already had the other knee done? Oh, okay. Your experience, yeah. You know what's coming,
I do,
yeah.
yep.
Oh, well, that's
Yep,
exciting.
yes, it is. I'm looking forward to it.